Dr. S. Chandrasekhar, MD, Professor and Head, General Medicine, Stanley Medical College, and Dr. Padma, MD, Professor, General Medicine, Balaji Medical College and Hospital, to moderate the next session. Dr. Prasanna Karthik, ma'am, Sir, Professor, Department of General Medicine, Savita Medical College. He graduated from PSG, ISMR, Coimbatore, and did his MD from Madras Medical College. He is a certified instructor and provider for basic life support and advanced cardiac life support from the American Heart Association. He is also a member of the Royal College of Physicians, London, American College of Physicians, and Association of Physicians of India. He has a vast working and teaching experience throughout the years and has been the guide for several significant research works. Our lecturer is going to talk upon the topic Young Onset DM, a systemic approach in hope to teach the young generation how to beat this. Welcome you, sir.
At the outset, I would like to thank the organizing chairman, Dr. T.K.V. Sharavanan sir, and his entire organizing committee for having given me this opportunity to stand before you and address you. So, without much ado, I will start my talk. Okay. I'm sorry. Can I have the previous slide, please? Okay. We are standing here in the centenary of the discovery of insulin. In 1921, insulin was first discovered by Banting and Best. And if you can look at this gentleman, if you look at the photo of the picture on the left, you would find Leonard Thompson. The photo you see here is a young 14-year-old Leonard Thompson, and you can see when he is 23 years. Diabetes was initially a disease of the young, because once you had diagnosed type 1 diabetes, you died young. That was the fate of a diabetic individual. Later on, after the discovery of insulin by this wonderful team of Best, Banting, Collip and MacLeod, we went on to see that type 1 diabetes started coming down, and we started seeing diabetes coming up in the elderly people. We started focusing more on type 2 diabetes. So this diabetes became a disease of the old. As you grew older, you started developing diabetes. But that is not the current scenario nowadays. What we find here is that diabetes has started affecting the young again. So, I would like to talk to you about a systematic approach to young onset diabetes. Before we start about it, I would like to ask your opinion about this. You have a 15-year-old male patient who is completely asymptomatic, was found to have a fasting blood sugar of 136 and had a postprandial blood sugar of about 194. His HbA1c is 6.6. Now, how many of you are going to say he's got a type 1 diabetic? How many of you are going to say he's got a type 2 diabetes? And how many of you think he's got MODY? Come on, let's have a show of hands, guys. How many of you think it's type 1? Nobody? Why not? He's just 15 years old. Why not it be type 1 diabetic? Okay. Would you like some more information? Okay. His weight is 105 kilograms. His BMI is 30.5. There's a strong family history of diabetes. The father was diagnosed at 35 years. The mother had history of GDM and was diagnosed to have diabetes at 32. Now what do you say is the diagnosis? Okay, so you want to wait some more time. Let's look at another case. You have a 15-year-old female, identical female, who's brought to the ER who is unconscious. The blood sugar is about 431. Urine ketones are positive. ABG has a high anion gap metabolic acidosis. HbA1c is 6.2. Now what do you think is the diagnosis? Could it be type 1? Could it be type 2? Could it be MODY? If you want more information, you have a 40 kg body weight and a BMI of 19 and no family history. So what do you think this could be? Type 1, type 2 or MODY? Now if you are not clear, we will go through the entire presentation and we will come back to these questions to answer it. Now, when you look at the clinical manifestations of diabetes in the young, it can present you in a variety of formats. We have something called the neonatal diabetes. You have a type 1 diabetes, you have a type 2 diabetes. Then you go on to have the monogenic forms, which are the MODI. And we also have something called the secondary diabetes. Now, neonatal diabetes is a very unique term. It occurs in diabetic babies who are less than 6 months of age. It can be transient or it can be permanent. And most of the time, the transient diabetes is due to overexpression of genes in the short arm of the chromosome 6. And it can recur later on in more than 50% of individuals. The permanent form of neonatal diabetes. Okay, I think I have a mix up with my slides. The slides are not reading. Okay, the time you have a permanent diabetes is because of defects in the insulin gene. You don't have to worry about it. We can go to the type 1 diabetes. Now, this is an autoimmune disease where there is a destruction of the beta cells of the islets of Langerhans. They usually present you between 6 months of age and 18 years of age. Remember, type 1 diabetes very rarely presents to you less than 6 months of age. And most of the time they are due to autoantibodies. There can be due to anti-insulin antibodies, anti-glutamic acid decarboxylase or GAD antibodies. You have the islet antigen 2 or the zinc transponder 8 antibodies. Okay, moving on to the stages of type 1 diabetes. You can remember that there are 3 stages, stage 1, 2 and 3. In all the 3 you have autoimmunity. But if you look at the glycemic level, in stage 1 you have normoglycemia, in stage 2 there is dysglycemia, and stage 3 is overt hyperglycemia. And if you look at symptoms, patients become symptomatic only in stage 3, but they are already having type 1 when they are in stage 1. So, the diagnostic criteria, if you look at it, if you can detect only the antibodies, but the fasting blood glucose and the postprandial blood glucose are within normal limits, you say the patient belongs to stage 1. Whereas, if there is an impaired glucose tolerance or an impaired fasting glucose, along with the presence of autoantibodies, you can think about stage 2. And most important thing you should remember is that autoantibodies can become negative by the time you diagnose type 1 diabetes, when they present to you clinically. So, patients can present you with overt hyperglycemia, but may not have antibodies. This is something that you need to remember. If you can look at this picture, the top picture shows the number 1 in the top picture. If you can see, those are the beta cells in the islets of Langerhans. So, the islets of Langerhans in the pancreas along with the beta cells, you would find that they are not infiltrated by the lymphocytes. Whereas, if you look at the bottom picture number 2, you would find that there is an encroachment of blue dots. And a magnified view, you can see the lymphocytic infiltration in the islets of pancreas. This is a very classical feature for a type 1 diabetic. So, when you look at type 1 diabetic, the diagnosis is not very clear at the time of presentation. But what are the points which can favor a diagnosis of type 1? Would be an younger age of onset, a lower BMI, a presentation of the first time with ketoacidosis. If somebody presents to you for the first time with ketoacidosis, think of type 1 diabetes, and a blood sugar which is more than 360 or 20 millimoles per liter at the time of presentation. A family history of diabetes, especially a younger onset of diabetes, tends to favor against type 1. Type 1 generally tends to be sporadic than familial. And Asian and African patients will have a lesser tendency to have detectable autoantibodies in their blood. So, just because somebody is antibody negative may not rule out a type 1 diabetes diagnosis. And you can also remember that the skin tags, acanthosis nigricans, which are markers for insulin resistance, are generally absent in these patients. And obesity may be present like a general population, but most of these patients are going to be underweight. And the C-peptide levels are usually low or undetectable. Now, when you go on to type 2 diabetes, it is more a genetic disorder. It's going to become a multifactorial disease. And you can find that there is an increase in the insulin resistance or a hypofunctioning pancreas. So, either there is a problem with the supply or there is an increase in the demand. And it can present from any age from 10 years onwards. Now, this is something alarming. We generally tend to think type 2 diabetes presents to you in the 3rd, 4th or even the 5th decades of life. But now there are enough number of reports to say you can have a 10-year-old diabetic with type 2 diabetes. A child who's 10 years is going to live for the next 60, 70 years with type 2 diabetes. So, imagine the burden he's going to have. And this is something more remarkable. About 25% of the diabetics from 25% of the patients from India who are below 25 years of age is going to be type 2. We generally tend to think of them as type 1, but they are going to be type 2 and they are going to have a difficult course in management. Now, one of the reasons attributed to this increase in the prevalence of type 2 diabetes is the prevalence of obesity. As obesity increases, we say more insulin resistance occurs and there is more type 2 diabetes. But this alone may not be the reason. There is also something that we need to remember, that Indian youth, especially children from India, have a higher propensity for beta cell dysfunction. Not only are they going to have insulin resistance because of the Western diet, but basically they have a lower threshold for beta cell function. So the mixture of these two is leading to an increased prevalence of type 2 diabetes among the young. Now again, at presentation we are not sure it's type 1 or type 2. The points which can favor a type 2 diagnosis would be a higher BMI at presentation, absence of ketosis even with a higher blood sugar. If there's a strong family history, especially of gestational diabetes mellitus in the mother, you can think of type 2. And C-peptide levels, if you can do, are generally detectable or quite high. Now, if you look at the American Diabetic Association screening guidelines for type 2 diabetes in children, the first statement says, at the onset of puberty or 10 years of age or whichever is earlier. That means you have to start screening at a very, very small age because of these patients having a propensity for obesity. So if you are overweight or you are having obesity, you need to be screened. If there is strong history of GDM, as I said, and the ethnic background, Asians, Africans and Pacific Islanders, and if the patient is exhibiting signs of insulin resistance like acanthosis nigricans, a polycystic ovarian or even a dyslipidemia, you need to screen for diabetes mellitus. Okay, moving on to the maturity onset diabetes of the young. It's another entity which can present in a youngster. So it was initially found out in the year 1974 where they had a mild diabetes and it was running in families as autosomal dominant. In 2009, the diagnostic criteria became well established. One, it has to have an onset at before 25 years of age in at least one family member. You needed to have presence of diabetes in 2 more generations at least, and there should be absence of beta cell antibodies and a sustained endogenous insulin secretion. That means even there is no requirement for insulin initiation in these patients, or the serum C-peptide level remains more than 200 picomoles even after 3 years of treatment. Now if you look at the beta cell, you can see there are different areas where it can happen. The most common MODY that you see is MODY type 2. It's because of the defects in the gene for glucokinase, GCK. The other nucleus encryption factors, including hepatic nucleoside transcription factor 4 alpha, 1 alpha, 1 beta, contribute to MODY type 1, type 3 and type 5. The MODY type 2 is the most common thing that you see. More than 25% of patients with MODY may have MODY type 2. The patients are usually asymptomatic. That's one of the things that this disease, you do not identify it unless you go screen for it. A random or a routine screening for diabetes, especially in adulthood or youngsters in schools or during gestation, you do pick up a mild hyperglycemia, but they have generally very few complications because it's a very mild form of it, and the HbA1c usually is between 6.5 to 7%. Now going on to MODY type 3, this is the second most common type. Here it is because of HNF1 alpha gene mutation. The hyperglycemia usually progresses and becomes worsen as the disease worsens. One thing you need to remember is the postprandial glycosuria precedes hyperglycemia. This is because HNF1 alpha also has the role in the renal tubular maximum. So they have a reduced threshold for glycosuria. So these patients present you with glycosuria before they have hyperglycemia. Going on to MODY type 1, which is again less than 5% of all MODY, you have a gene mutation in HNF4 alpha, and this HNF alpha is also having a role in the pancreas and the kidney, but you don't have glycosuria unlike MODY type 3. So you need to remember between MODY type 1 and type 3, glycosuria is going to be the differentiating factor. These patients can also have sometimes lipid abnormalities because of the role of HNF4 alpha in apolipoprotein A3, C2 and B metabolism. Going on to MODY type 5. Okay, I think one slide is missed. The MODY type 5, you need to remember, these patients present to you with a combination of renal disease and diabetes. They present to you with non-diabetic kidney disease. Normally in a diabetic, the kidney affection is because of the diabetes, but in MODY type 5, the non-diabetic kidney disease in the form of either cyst or renal agenesis is predominant, and they will present to you with a mixture of diabetes and non-diabetic kidney disease. That needs to be important, and usually you can also present to you with hypertriglyceridemia. The last but not the rare presentation in India is called fibrocalculous pancreatic diabetes, FCPD. Now, this is quite uncommon. This presents to us predominantly because of the calcification of the pancreas leading to a destruction of the pancreas. These patients are usually insulin deficient and require a long-term therapy with insulin and can present to you with frequent episodes, infrequent episodes of diabetic ketoacidosis. Now, how to differentiate in a nutshell? If you think of type 1 diabetes, look at the age of onset. They usually present to us in early childhood or early adolescence, whereas type 2 presents to you in adolescence or early adulthood, and MODY can present to you before 25 years of age. Family history is strongly positive in patients with type 2 diabetes and in MODY, but uncommon in type 1. Obesity is very common with type 2 diabetes and uncommon in either type 1 or MODY. Insulin resistance features are usually present with type 2 diabetes and uncommon with type 1 and MODY. C-peptide levels are undetectable in patients with type 1 diabetes, whereas they are normal or raised in patients with type 2 diabetes. And your autoantibodies can be detected in patients with type 1. Now, if you ask me to approach it, putting it in the approach, if somebody has a diabetes before 25 years of age, and if the patient is diagnosed less than 6 months of age, it has to be neonatal diabetes. With anybody else, if you say it's a sudden onset of hyperglycemia presenting to you for the first time with ketosis, patient is non-obese or insulin deficient, think of type 1, check for autoantibodies. If it's positive, you know it is type 1. If the patient has features of obesity, insulin resistance and is negative for antibodies, then it's possibly going to be type 2. But if the antibodies are negative and it's something in between with a family history, go ahead and think for MODY, which is maturity onset diabetes of the young. So less than 6 months, it's neonatal diabetes. Somebody presenting you for the first time with hyperglycemia, ketosis and underweight, think of type 1. Obesity, family history, presenting to you with insulin resistance, think of type 2. So going back to this case, now what do you think is the diagnosis? What should be the diagnosis? Is it type 1, type 2 or MODY? Yes, it is type 2 diabetes mellitus. What could be the diagnosis in this patient who is young? If you look at the BMI is less than 24, less than 20, you can present it as type 1 diabetes. So when you go on to evaluate a patient who is presenting to you with hyperglycemia, remember that not only do we do a fasting and postprandial blood sugars and a HbA1c, you need to think about doing either a fasting and a postprandial C-peptide levels, which can guide you about what needs to be the diagnosis. Consider the use of autoantibodies as appropriate. Not everybody who presents to you with less than 25 years of age, you need to do an anti-antibodies. You can think about doing an ultrasound abdomen to rule out an FCPD. Urine routine and ketones to rule out ketosis. Genetic testing need to be done on a needed basis. If you are suspecting MODY, yes, possibly you need to do it. The most important thing that you need to remember is you need to evaluate all your patients for complications if they are presenting to you with type 2 diabetes. If you are diagnosing type 1, don't screen for complications, because generally they are going to present to you with complications a little later. But if your type 2 diagnosis is being made, you need to screen the patients for complications then and there, because you do not know when they would have had the onset of the disease. Now, if you look at the treatment strategies available for patients, type 2 is the same. It's going to be diet, lifestyle modifications, and drug therapy, which means overcoming the obesity is going to be very, very important in these adults, because they are going to be treated as adult onset diabetes. The two drugs which are commonly approved are metformin and insulin. There is approval for use of long-acting GLP-1 RAs, exenatide long-acting, and liraglutide in children between 10 to 19 years of age. But I would prefer that we use metformin as a major idea. And SGLT2 inhibitors are now showing promise in the management of type 2 diabetes in children. And this is the other option for a type 1. If you are diagnosed with type 1, you are going to be on lifelong insulin therapy because your body is not. It could be a mixture of long-acting and short-acting frequent shots, or it could be the use of a continuous subcutaneous insulin infusion. It's become from a big instrument in the 1960s to a small pocket handheld device nowadays, which the patients can themselves program. And remember, MODIs type 1 and type 3 are very responsive to sulfonylureas. This is very important to identify and treat appropriately, because if you make a diagnosis of MODI type 1 and you put the patient on insulin, they will go for very high requirements of insulin and not be diagnosed correctly. They will only require small doses of sulfonylureas to get the same amount of control. MODI type 2 generally will not require any treatment. Thank you for a patient listening.
It's been a wonderful session. He has highlighted very clearly about how to differentiate type 1, type 2 and MODI, and the last table sums up all the points which he has told, and the hall is open for discussion. So,
good afternoon to everyone. I thank Professor Sharavanan for having us here to chair this important session. From my medical college, from Stanley Medical College, we get at least 3 or 4 students from Tagore. It's a long wait for me to visit this college. So of late, for the past couple of years, we do see the students coming on merit to our college, both MD and MS. It's a wonderful ambience and wonderful arrangements they've made. Coming to the topic, the diabetes in young, it's a very important thing. There are certain problems which we come across, particularly in our part of the country. The awareness is less. The people still think that the diabetes can come only in the 30s and 40s. But we often see almost a couple of cases or more than that presenting to us for the first time with hyperglycemia and ketosis in our emergency ward. So that is the scenario. The second thing is, though they are, once they are diagnosed, the next challenge is the acceptance. For a small kid or adolescent, it's very, very, very difficult to motivate the lifestyle measures and adherent to the therapy, whether it's insulin or OHA for that matter. The third is the psychosocial impact, the patient as well as the parents. It's again a very difficult time. So definitely what Prasanna has alluded to, so he has given a brief idea about how we can diagnose a diabetes at young age, how we can differentiate a type 1 from type 2, and as well as monogenic diabetes. It's very pertinent that we need to spend more time with these children or adolescents along with their parents to motivate and explaining them the importance of having a good control. So that's a real challenge for all of us. One more thing is, there is one more variety of diabetes that is also quite common in our part of the country, that has been reported by Haguja and Tripadi way back in 1963. Previously, it was called malnutrition-related diabetes. Now the terminology comes under with along with the FCPD, fibrocalcific pancreatic diabetes, that is malnutrition-modulated diabetes. But still, we do see patients who are chronically malnourished. They come to us because of the poor beta cell function and the secretory capacity. They come to us with hyperglycemia, severe hyperglycemia, but no ketosis. So this is also another situation we come across at least once in 2 months or 3 months. So this is a very tricky situation, a challenging situation. A patient who develops diabetes at young, that's a very important topic what we have, the deliberation from Dr. Prasanna Karthik. Unfortunately, the type 2 diabetes we do see at a very younger age group. That poses again another, adds to the burden of the health cost. So I think he has delivered a very nice talk. And can we take some couple of questions from the postgraduates or from the audience?
If there's no questions, we can continue. Thank you for your valuable comments, sir.
Thank you.
Thank you all. Thank you.
Karthik sir, with a token of appreciation. Before moving to the next session, I'd request Dr. Nasrin ma'am to felicitate the moderators, Dr. S. Chandrasekhar sir and Dr. Padma ma'am.